Okay. Now, any other questions or comment? I know we are running a little out of time, but I'm sure that we, as one student group at least, it's dropped off. We are still more or less on track. So, any other comments or questions about the last talk? Okay, so then if this is not the case, let's move forward to the next speaker. It's Alexander Keppler. He's actually a surgeon. I haven't seen him, probably he's here. And he is supposed to talk about mobility and physical activity in orthogeriatric patients.
Yeah, hello together. Good afternoon. Thank you, Martin, for the invitation, for the kind invitation, and for the chance to give a short overview over my topic, orthogeriatric patients and the role of mobility in this group of fragile group of patients. So you can see my presentation, hopefully. Yes. Perfect, wonderful. Then I want to start already. The topic of my talk is the mobility and wearables in orthogeriatric patients, and I want to give you a short overview over the problems we have in these patients from the surgical side, and also the opportunities we get for these patients from the wearable side. So I want to look at two sides in of my presentation. So, no disclosure at all. And what is our motivation? Mobility is a crucial factor in old age. So we know that mobility is really, really important for these patients. And if reduced mobility represents a significant risk factor for social withdrawal. So Kamalanda shows this in a study some years ago, that a lot of patients need a walking frame or something other help after a hip fracture, and so a withdrawal in social isolation happens. And trauma is one of the most frequent events in older people that leads to this loss of mobility and independence, and also to the high health, to the high economic costs, such a nursing home admission. This is a really, really hot topic. But in general, immobilization poses a high risk to the patient. Not only the social isolation, we have also risk for the body system. It has negative consequences for numerous organ systems, leads to a further derotation in condition. The backpack is packed already with the trauma, and this is all made heavier by immobility. The goal in the orthogeriatric traumatology care must therefore be start already in the emergency room and then avoid immobilization starting there. This must be the top priority for us, and we need a rapid surgery, and also we need a rapid rehabilitation for these patients, and therefore we need a good structure in our hospitals. And this is really a high problem, actually, not only in Germany, all over the world. And a lot of people are try to improve the structures for these patients to reduce the risk of immobility. If you look at the consequences of immobility on the muscles, the muscle is also organ system like the heart or the brain or the kidney, you will notice that the first week of immobility is associated with the greatest loss of muscle mass. Yeah, we know also this from the bed rest studies Johan Rittweger and the NASA and the DLR performed, and that this loss cannot be recovered later, even through intensive training, which is no problem in young patients. The loss of muscle mass has many negative consequences, leading to more falls, weakness, metabolic problems, and is an essential part of the frailty syndrome, which for many of our patients is really high risk. So if you see here, we are studying here, and this is the frailty syndrome. It's come over and more in the literature the last years, that old people are suffering from this frailty syndrome, and this frailty syndrome is one of the causes for the poor outcomes, and it's multifactorial. It's from the aging, the lifestyle, the living conditions, but one key point to this frailty syndrome is sarcopenia, and sarcopenia is also linked to the mobility in these patients. But what we need now from the surgical side of view to improve mobility and to reduce frailty and to reduce also the care costs of our patients, we need a total weight bearing. So, and this is really a change in the last years. So for many, many years, we were very scared about a full weight bearing in these patients. Yeah, we do a fancy operation, we put a lot of metal into the bone, to the bone, plates, nails, and so on, prostheses. And then after the operation, we were not sure if it's fixed enough or not. So there may be a risk of reduction lost. And so we told the patients for many, many years, be slow, be careful, don't walk too much, don't do a total weight bearing. But we see it's not possible. Old patients cannot perform a partial weight bearing. This was really a change in our treatment protocols. Our group can show this some years ago, that the inability of older adults with hip fracture for postoperative weight bearing is not possible. If you say the patient just use your half height or your half body weight, forget it. They walk totally normal with the full weight bearing. And this is really important for us surgeons now, because we have to do the best possible surgery and to improve the stability as so good as